Yeah. Thank you. Yeah, apologies for not speaking German. I didn't like it at my secondary school, so I dropped it rather soon. Should not have done that. And thank you very much for the invitation. It's really a pleasure to be here. Although I must admit it's a rather doubtful honor, because there's been some bad advertisements around hypothermia in the past years. You will have read it in the major papers, and was especially concerned about the update in the title, because that relates to the studies I will now come to. You will probably have seen all these studies. The bad news started with the publication of the TTM trial in the New England Journal. It was a trial in patients with cardiac arrest, which found that hypothermia did not confer a benefit. Same year, in the JAMA, a paper on bacterial meningitis, hypothermia for bacterial meningitis. I think that's a bad idea in the first place, but they also concluded that hypothermia did not improve outcome. Third trial, published last year, 2015, hypothermia in children with cardiac arrest. And again, they found that hypothermia did not confirm a significant benefit. And finally, and that's the trial I think almost killed hypothermia, was a trial of in patients with traumatic brain injury, where they also found that hypothermia did not result in outcomes better than those with standard care alone. So, to be honest, it feels like I have to explain the advantages of open borders in Europe at this time, or if I would be in the UK, to tell them why the European Union has advantages. So, the first question is hypothermia still a promising treatment for patients with acute stroke? And I was wondering if you have heard this about your opinion. So, who thinks that after all this bad news, hypothermia should still be tested and is a promising treatment? Fortunately, at least a few. And who thinks it isn't? Who think it's over and out? We shouldn't test it anymore. Okay, I thought Austrians would be more polite to their speakers. Okay, I think hypothermia still does have advantages. And for me, it started in 1994 when I was a PhD student, and the topic of my research was to test the effect of antioxidants in a rat model of ischemic stroke. And to this end, I had to occlude the middle cerebral artery in a rat, and to test whether I really occluded the middle cerebral artery, I had to measure blood flow with laser Doppler flowmetry. And to be able to measure that, I had to make a large hole in the skull of the rat, so to perform a hemicraniectomy, like Urs Fischer does every day. And obviously, I maintained the central body temperature with a rectal probe and a feedback system. So the body temperature was at 37 degrees Celsius all the time. And after 3 hours of middle cerebral artery occlusion and this hemicraniectomy, I found no infarcts, or only very small infarcts here. These are TTC stained images, where the TTC stains the viable tissue red, and the dead tissue, so the infarcted tissue, remains white. So this here is an infarct. Not very clear, but that's the infarct. And after I'd killed some 30 rats or so without obtaining any relevant infarct, I started measuring temperature of the brain, and I found that the brain temperature was 34 to 35 degrees Celsius. And then I kept brain temperature constant also at 37 degrees Celsius. And I found these very large infarcts here and there. So my conclusion at that time, and I could stop my presentation now, is that hypothermia improves outcome after stroke. But of course, this was just a single lab, single person experience. And my thesis should be on antioxidants and not on hypothermia, so I was not allowed to continue this research into hypothermia. Obviously, it could have been a coincidental finding, and it was not randomized and not blinded. And there was several other reasons why this is not proof that hypothermia is beneficial. And obviously, I was not the first one who had made this observation. Already in 1956, so 60 years from today, earlier than today, with the exception of 1 month, there was a publication from the United States which showed that hypothermia in dogs reduced infarct size. So the treatment is already 60 years old. And by 2005, there had been 101 publications describing the effect of hypothermia, with 277 individual comparisons involving over 3,000 animals. And I don't say they were all killed for the right purpose. And these are the effect sizes of the reduction in infarct volume in each of the individual comparisons, shown as black dots, which form a line because there are very many, surrounded by the 95% confidence intervals. So now you can see that there were some studies that found no effect of hypothermia, and also some studies that found 100% protection through hypothermia. But the overall protection, the overall reduction in infarct volume was 44%. And the same applies to functional outcomes in these rats, or animals, mainly rats and mice, 46% protection. So it's also not surprising that the lower the temperatures tested, the higher the better the outcome. So the larger the reduction in infarct size. So with temperatures of 31 degrees Celsius or below, you get about 60% reduction in infarct size, but even a very modest temperature reduction of 35 degrees Celsius reduced infarct size by about 1/3. But you may wonder why we should believe these animal studies of hypothermia when other neuroprotective strategies have failed in clinical trials. And there have been many. And I think the example I like most, because it's recent, published in 2014, I think, and because it was a very good trial, was a trial of magnesium, the FAST-MAG trial in the States, testing magnesium sulfate. And they start their background in the abstract with magnesium sulfate is neuroprotective in preclinical models of stroke, like hypothermia. And they enrolled 1,700 patients, and one very good thing is that they started treatments at a median of 45 minutes after the onset of symptoms, because it was an ambulance trial. So incredibly quickly. But they found that it didn't improve outcome at 90 days. And this may be because in the ischemic cascade, which you as stroke neurologists probably know by heart, magnesium here only improves the magnesium block. And other neuroprotective drugs, potentially neuroprotective drugs like nimodipine, tested in many clinical trials, only reduce the calcium increase in the cell. And antioxidants, the ones I tested, tyrillizate and NY059, only reduce the amount of radicals in the brain. So they affect only a single step, whereas hypothermia affects a wide range of cell death mechanisms and is therefore, I think, more likely to be effective. And in systematic reviews of animal stroke studies, hypothermia was the most robustly effective treatment, about twice as effective as thrombolysis with TPA, but obviously these were not randomized studies comparing hypothermia with TPA. So These are, you could say, historical controls. But another reason why I think hypothermia could work is that it has already been tested in phase 3 trials in similar conditions. As you know, it has been shown effective in post-anoxic coma in patients with cardiac arrest and in neonatal hypoxic ischemic brain damage. But several trials not effective in traumatic brain injury, and I showed you one example in the introduction to my talk. So there are several methods to cool patients. I'll explain the most commonly used ones. The first one is surface cooling, in which you first infuse about 2 liters of ice-cold saline in a patient, and this is safe. And then keep the body temperature constant at 34 to 35 degrees Celsius. Or you can do endovascular cooling. You insert a cooling catheter into the inferior vena cava and cool the blood. And there are several other methods which are not that frequently used. And I think one important thing is that it can be done by a neurologist. We don't need the neurosurgeon or an interventional radiologist. And there have been a few randomized clinical trials in awake patients with acute ischemic stroke, also a few in patients on an ICU where they were intubated and ventilated, and all now focus on ischemic stroke. There are, as far as I know, 2 trials ongoing in patients with intracerebral hemorrhage, but no published evidence of benefits or side effects. So 3 published phase 2 trials and 2 other unpublished trials. One, because it was just completed, a small phase 2 trial, Coolest, and one phase 3 trial, which was terminated prematurely after inclusion of 48 patients against a target of 900, I think. And it was terminated more than 10 years ago, but still unpublished, which should not have happened. So, but you can see that the overall experience with cooling in these trials is very small, because over at least a 12-year period, only 102 cooled patients. And they used different methods of cooling, endovascular and surface, and also different targets from 33 to 35 degrees Celsius. Different delays to cooling, 4.5 to 12 hours, and also different durations, 9 to 24 hours. So it's very difficult to interpret these findings and to do a proper meta-analysis. One thing we do know is that cooling does increase the risk of pneumonia. In this meta-analysis, which has also not yet been published, you can see that there's a strong increase in the risk of pneumonia. So in the hypothermic patients, 39%, and in the controls, 8%. So when your mother used to tell you that you should put on a coat when you went outside in winter, she was right. And with regard to outcome, there are no available meta-analysis, no recent meta-analysis. The only one that's more or less available is the result of an individual patient meta-analysis that Bart from Nottingham performed, where he found that the odds ratio for a poor outcome was 0.72, which means that there's a trend towards benefit, of course, with these very few patients cooled with very wide confidence intervals. And this is consistent with an absolute risk reduction of 7.6%, which is more or less similar to thrombolysis within 3 hours. So we have animal studies that were very positive, phase 3 studies in comparable conditions, and pilot studies in ischemic stroke. So there's every reason to start a phase 3 trial, and this trial has started. It's the EuroHype 1 trial, funded by the European Union. And this is a multi-center randomized controlled clinical trial of hypothermia for acute ischemic stroke. And the objective is to determine whether systemic cooling to 34 to 35 degrees Celsius improves functional outcome in these patients. The trial design, very briefly, it's a randomized multi-center international clinical trial, open. Of course, it's impossible to do this blinded, with a blinded outcome assessment, 1,800 awake patients with ischemic stroke, cooling for 12 hours, started within 6 hours and within 2.5 hours after onset of thrombolysis. And the primary outcome, not surprisingly, is the score on the modified Rankin scale at 90 days. And the first patient has been included in November 2013, but inclusion is rather slow. Is that correct, Sir Dimitri? So we could use some help from Austria. The target temperature was selected based on evidence from animal studies. The cardiac arrest trials used a temperature of 32 to 34 degrees Celsius. There have been pilots in patients with ischemic stroke using 33 degrees Celsius, but there were more cases of pneumonia. Other pilots have used 35 degrees Celsius, so Eurohype 1 as a target temperature of 34 to 35 degrees Celsius. And now, as already mentioned, we reach this temperature by infusion of an intravenous fluid, usually normal saline, cooled to 4 degrees Celsius over 30 to 60 minutes, followed by systemic cooling for 12 hours. And obviously, it's not nice to be cooled, mainly leads to shivering, discomfort. And this is prevented by infusion of pethidine and buspirone, an old neuroleptic drug used as a pill, oral medication. But unfortunately, pethidine, that's not a very, it's an old-fashioned drug. It causes a dose-dependent sedation and also nausea and vomiting. And for this reason, these patients also get ondansetron to prevent the nausea and vomiting. So you may wonder whether we need any additional stroke treatments at all, because we have the mechanical thrombectomy now. But I would like to remind you that, of course, the benefits of this treatment are very large. This has been, again, discussed yesterday within the Mr. Clean trial, which was the largest, an absolute risk reduction of 14%. But you can see, this is the bar of the intervention group, so the patients who were randomized to endovascular treatment, they still had a high risk of a poor outcome. And this was the least selected population of all the intra-arterial treatment trials. And the Extend IA, that was the trial with the largest benefit, an absolute risk reduction of 31%, but in a very selected population. And still 1/3 of the patients had a poor outcome. So there's a need for additional options, I think. You may also wonder whether we can't use something more simple, also related to temperature. And now you will know that temperatures above 37.5 degrees Celsius, sub-febrile temperatures, and fever after stroke occur very frequently. 1/3 of the patients on the first day. They have consistently been associated with a poor outcome, and guidelines recommended the treatment of fever. The American trials are a bit more aggressive than the European ones. The European ones the new ones are now rather neutral, but the American ones still recommend treatment of fever. But this may be too late, because then the patient already has had fever for some time before you start treating, and prevention might be better. And this could be done by something simple as paracetamol. This has also been tested in the PICE trial, and this was a randomized trial, 1,400 patients with more or less normothermia, treated with paracetamol, 6 grams a day for 3 days, started within 12 hours of symptom onset. And here you can see the baseline temperatures. You can see that the large majority of patients indeed had a normal temperature at baseline. and only few had subfebrile temperature or fever. And now, the results are not extremely extreme. Paracetamol reduced body temperature by 0.3 degrees Celsius, but it also reduced the risk of having a subfebrile temperature or stroke or a fever at 24 hours from 30% in controls to 15% in patients treated with paracetamol. And there was a trend towards a benefit. Here a higher odds ratio indicates a benefit, but it was just not statistically significant, so the trial should have been larger. But if true, we would have an extremely safe, simple and cheap treatment for patients with stroke, with intracerebral hemorrhage or ischemic stroke. And this is now again being tested in the European Precious trial, which is a open trial with blinded outcome assessment, 2x2x2 factorial, with 1,300 patients in them with ischemic stroke or ICH. Open treatment, 3 treatments tested, very simple treatments, cheap treatments, and safe treatments, and all with the intention to reduce infections and fever. Ceftriaxone, paracetamol, and metoclopramide. And here again, the primary outcome is the score on the modified Rankin scale at 90 days. So these are the participating countries. Austria is missing, but maybe added later. And this is supported also by the European Union under the Horizon 2020 program. So what about the papers with the poor results of hypothermia, which I mentioned in the beginning? First, the TTM trial, the cardiac arrest trial. I think the main issue here is that they tested 33 against 36 degrees Celsius, and 36 still is not normothermia, I think. So actually they tested 2 levels of hypothermia, in my view. The children's trial, also with cardiac arrest. So they said that there was no significant benefit, but if you look at the results in the abstract, then you can see that patients treated with hypothermia more often had a good outcome, 20% versus 12% in controls, but the result was just not statistically significant. But that's, if true, this is a very large absolute risk reduction, 8%. And this also applies to survival, where this was 38% in the children treated with hypothermia and versus 29% in control. So I think the conclusion should not be that there's no benefit of hypothermia, but that it's just still uncertain. And finally, the large traumatic brain injury trial. There, the most surprising thing is that treatment could be started within 10 days after trauma. And that was because the trial was mainly aimed at reducing intracranial pressure. And there were only 9% of the patients were treated within 12 hours after the trauma. And in a subgroup analysis, which was not published in the original paper, but in an online supplement, you can see that the patients treated within 12 hours from traumatic brain injury, that was more or less the only group where there was a strong trend towards a benefit of hypothermia. But obviously with 35 patients, it's difficult to reach statistical significance. And the interaction was, they say, just not statistically significant, but you may discuss about that. So even this trial, which was seen as a very negative trial for hypothermia, still has some promise for hypothermia. So in conclusion, I think that cooling is still a promising therapy for acute ischemic stroke, and cooling can probably be combined with reperfusion strategies, so we can use it even in our patients treated with thrombectomy, and prevention of fever may be effective in a much larger and unselected population of patients. Thank you.
Thank you very much. The presentation is now open for discussion. I ask for questions. Maybe I can start with a question. Are there any known effects of hypothermia on blood coagulation? Is there a risk that the thrombus extends, and is there any effect on the action of alteplase?
No, that's a very good question. There are a few sides to this. If you have very deep hypothermia, but then you have to go below 32 and even below 30 to obtain really clinically relevant effects, then the blood coagulation is reduced, because these are mainly enzymatic processes. So this would be in favor of hypothermia, but then you have to cool very deeply, which also has a risk for the heart. Then you might get a cardiac arrest or other serious cardiac disease. But in clinical practice, if patients are treated with alteplase, it's also an enzymatic process, then in theory, every degree Celsius reduction in body temperature would lead to something like 5% relative risk of reduction of dissolving the clot. So then hypothermia would have a detrimental effect. But hypothermia is started usually after thrombolysis, when the infusion is already completed. And the clot has hopefully already been dissolved, and as you know, the half-life of alteplase is very short. So if you start after the infusion of alteplase, the effect on clot lysis is probably very limited. But yeah, there's no evidence in patients that is really that has no effects. But on theoretical grounds, we believe that there's no relevant effect on clot lysis.
Thank you. Are there any other questions? Can you briefly give us your estimate whether Eurohype, you said that it is behind schedule.
Yes.
Has this study a realistic chance that it will recruit enough patients that we get the answer?
It's a nasty question. If the Austrians will help, we will have we'll have a better chance of completing the trial. Now, to be honest, I think it could be completed if not the time frame for such trials funded by the European Union is very restricted. They say you have to complete a trial within 5 years. And that will be very difficult, and that will actually be impossible, because the 5th year will end in 1 year from now. So Dmitry Staikov is one of the other co-principal investigators, and I think Dmitry also thinks that we will not manage to have these 800 patients included by next year. But we aim to ask for an extension of the trial, and then I still think it should be possible to get at least close to these 800 patients, also because we have now simplified the protocol. And I personally think even if we would only have half of this amount, then we would obtain very relevant information on the effect of hypothermia in patients with ischemic stroke. So, of course, I can't say it in public, but I will still do. I'm already happy with 400 patients.
Thank you very much. Thank you for your presentation. Thank you for coming to Krems.
You're welcome.
And if there are no other questions, we proceed to the next presentation.
Okay. Thank you also from my side. I hope a lot of colleagues will participate.